want to perform hand hygiene and provide privacy to the patient. Then introduce yourself to the patient and explain what you're going to be doing. So hello, my name is Sarah and I'm going to be your nurse today, and I need to perform a head to toe assessment. Is that okay with you?
Yes.
Okay, then proceed and look at their armband. So while you're doing this is going to help you make sure you have the right patient, and you're going to be testing them to see if they know who they are, their date of birth, and ask them some other questions to assess that neuro status. So state your first and last name for me.
First name is Ben, last name is Dover.
Okay, and your date of birth?
8/28/82.
Okay, and do you want me to call you Ben or Mr. Dover? What do you prefer?
Ben will be fine.
Okay, so Ben, can you tell me where you're at?
I'm at the hospital.
Okay, and can you tell me what we're doing here today?
Head to toe assessment.
Okay, and who's the President of the United States?
Donald Trump.
Okay, so he answered all of those correctly, and he's alert and he's oriented ×4. He knew who he was. He was able to tell me his name, his date of birth, where he was, what we're doing, and current events. So we can chart alert and oriented ×4. Face that he can't control that are involuntary, we don't see anything, and we're making sure that the face is symmetrical. There's no drooping on one side like in this picture. There's drooping on one side of the face, and this can be seen in Bell's palsy or in stroke. And we're also just looking at the eyes and the ears. Are they at the same level? And while we're here, we're going to go ahead and look at the facial expressions and test cranial nerve 7, which is the facial nerve. So can you close your eyes tightly for me and open them up? Okay. Now smile for me, frown, and puff out your cheeks. Okay, and he did that with ease, so that cranial nerve is intact. Next, what we're going to do is we're going to palpate the head, the cranium. We're going to check for any masses, indentations, look for skin breakdown, any infestations. And for this part, I like to wear gloves. So let's look at the hair. So what we're doing is we're feeling for any masses, indentations, and also with this, we're looking for any skin breakdown. And if your patient's immobile, you really want to check the back of the head back here because they're laying on it a lot, and there can be breakdown back there. Also, while you're doing that, look inside the hair. Make sure there is no infestations like lice, and there's no abrupt, like rounding areas of baldness, which could represent alopecia. Then after that, since this patient has a beard, you want to check the beard as well, any lesions, any infestations or anything like that, and just look around. And then once you're done with that, what you want to do is you'll doff your gloves and perform hand hygiene. Next, what we're going to do is we're going to find the temporal artery and we're going to palpate them bilaterally, and they are both found right here. And his are about a 2+. And then while we're right there, we're going to go ahead and test cranial nerve 5, which is the trigeminal nerve. And this nerve is responsible for many things like mastication. So what I'm going to have you do, Ben, is I'm going to have you clench your teeth, like bite down for me. And I'm going to feel the masseter muscle, which is right there, and it should be a nice firm ball. And then feel the temporal muscle. Now what I'm going to do to also test that nerve is have him try to open his mouth against resistance. So try to do that for me. Okay, and he can do that. Now, while we're here, we're going to go ahead and feel the temporal mandibular joint. And we're going to feel right here, and I'm going to have you open and close your mouth. And I'm feeling for any grating or clicking sensations, and I feel none. Then we're going to palpate the sinuses, and I'm going to put pressure on these 2 sinuses right here, and you tell me if you feel any pain, okay? So the maxillary?
No.
And the frontal?
No.
Next, we're moving down to the eyes, and we're going to inspect the eyes first. And we're looking at several things. We're looking at the eyelid. We're looking at the sclera, which is the white of the eyes. We're looking at the iris. We're looking at the pupil. And we're looking at the conjunctiva. So you shouldn't see any swelling of the eyelids. You should see that the sclera is white and shiny. It shouldn't be yellow like in jaundice. And the conjunctiva, when you pull down the lower lid, have the patient look up, it should be nice and pink. It shouldn't be red. You shouldn't see any drainage or anything like that. Then look at the eyes. How do they set in the eye socket? Are they equal? For instance, is there any strabismus? Is there a cross eye where one eye turns in more, turns out or up or down? And these eyes are normal. There's no strabismus. Next, you want to look at anisocoria, where one pupil would be smaller than the other pupil. Are they equal in size? Normal pupils should be 3 to 5 millimeters in their measurement, and here his are about a 3, and they are equal. Next, what we're going to do is we're going to assess some cranial nerves. We're going to be looking at cranial nerve 3, which is ocular motor, 4, trochlear, and then 6, which is abducens. And we're going to do several tests to check their function. The first one, what we're going to do is we're going to be looking for any involuntary shaking of the eye called nystagmus. And how we're going to do that is we're going to take our pen light, we're going to hold it about 12 to 14 inches away from the patient's nose. And Ben, what I want you to do is keep your head still, don't move your head, and just use your eyes to watch where I move the pen light. And as you're doing this, you're going to perform it in the 6 cardinal fields of gaze, and you're just going to move it, and you're looking for any involuntary shaking of the eyes. So here we go. Next, we're going to see how reactive the pupils are to light. And to do that, we're going to dim the lights a little bit, and we're going to have the patient stare off at a distant object. That helps dilate those pupils. And then we're going to shine, using our pen light, in at the side. And we're going to see how that pupil responds. It should constrict. And then on the other side, it should constrict as well. So say their baseline pupil size was like 3 millimeters. It should go down to 1 millimeter, and it should happen on both sides. Okay, so Ben, stare off at that object right on the wall over there for me. Okay, and that dilates the pupils, and we're just going to shine light in at this side. Okay, constrict, constrict. Okay, let them dilate again, and then go to the other side. Do the same again. And they both constricted in equal size. Next, what we're going to do is we're going to check for accommodation, and how we do that is we turn the lights back on. We just previously had them dim, but we now make it light again. We're going to have him stare off at a distant object. That helps dilate the pupils, and we're going to take a pen light. You can use a pen light finger, and you're just going to slowly move it inward to the nose. And what you're looking for is that those pupils constrict, they accommodate, and the eyes cross while looking at the pen light. So here we go. Stare off in the distance, please, and I don't want you to move your head or anything. Just keep it real still and just follow this pen light, okay? Ready? Okay, so now we can document, because we just checked all of the things with the eyes, we can document that the pupils are equal, round, reactive to light, and they accommodate. So that's where that acronym PERRLA comes into play. Next, we're going to move on to the ears. So first, what we do is we inspect the ears. We look on the outside of the ear. Is there any abnormalities, any redness, any drainage, anything like that? And Ben, are you having any pain in your ear? No. Okay, and sometimes if you have patients who've had long-term gout, on the helix of the ear, they may have what's called a tophi, which is an accumulation of like a whitish, yellowish uric acid crystal on the skin. So if you ever see that, that is what that looks like. Next, we're going to palpate on the ear. We're just going to move it around. And Ben, tell me if you have any tenderness whenever I do that. And feel any abnormal masses or lesions, and then move the targets a little bit. Does that hurt or anything like that? No. Okay, so no pain or tenderness. Then we're going to palpate the mastoid process, which is the big hump behind the ear, and we're looking at it. Is it swollen? Is there any redness? And whenever I touch on it, Ben, does it hurt? Yeah. Okay, and just see if the patient reports any tenderness with that. Then while you're there, you can use the otoscope to inspect the tympanic membrane. And remember, the tympanic membrane should be a pearly gray translucent color and should be shiny. So for an adult, you're going to pull the pin of the ear up and back. And we're just going to inspect it. And also, while we're looking at that, we are looking at the cone of light. And remember, the cone of light in the right ear should be at 5 o'clock, and in the left ear should be at 7 o'clock. Next, we're going to do one more thing with the ear. We're going to test cranial nerve 8, which is the vestibulocochlear nerve. And what I'm going to do is I'm going to include one of his ears and then whisper 2 words on the other side. He needs to tell me what I said. So, you ready? Mm-hmm. Okay, I'm going to include this one.
Apple, banana.
Okay, very good.
Cat, dog.
Okay, and that nerve is intact. Next, we're going to move on to the nose, and we're going to inspect the nose. We're going to make sure it's midline on the face, which it is. We're going to look at the septum. Is it deviated, anything like that? And ask the patient, are you having any trouble with your nose? Are you having any drainage or anything like that? No. And you want them to you want to check the patency of the nose. So then I'm going to have you occlude one side of the nostril, breathe out the other, and vice versa. Okay, heard airflow. Airflow, nice and patent, because sometimes people can have polyps that can block it or the deviated septum. Then you want to take your pen light and you just want to look inside the nose, look for any drainage, redness, or any like polyps or anything like that. And everything looks clear, I don't see anything. And then we're going to test the olfactory cranial nerve 1, the sense of smell. So Ben, what I'm going to have you do is I'm going to have you close your eyes and I'm going to put something in front of your nose and have you breathe in and smell, and you tell me what you smell. And whenever you do this, use something that's pleasant smelling, not something that's really stinky, because it could elicit like a gag reflex or something like that if the person has a sensitive nose. Okay?
Vanilla.
Okay, and this was vanilla extract, and that is correct. So that cranial nerve is intact. Next, we're going to move on to the mouth. And for this part, like to wear gloves. And if your patient is coughing and hacking, you might want to wear a mask with a shield so you don't get any mucus on your face or in your mucous membrane. So first what we're going to do, we're just inspecting the lips, make sure they're nice pink color, they're not chapped, there's no sores on them. And one thing with a lot of patients, whenever their oxygen saturations are low, their lips may turn dusky or blue color, so you want to make sure they're nice and pink because that can represent our oxygen level. Now let's inspect the inside of the mouth, but first let's test cranial nerve 12, which is the hypoglossal nerve. And what I'm going to have you do, Ben, is I'm going to have you stick out your tongue and move it side to side. Okay, and he does that with ease. Now what we're going to do is we're going to inspect the inside of the mouth. You'll need a tongue blade for that. And just open up your mouth for me, and I'm going to look on the inside of the cheeks, nice and pink, don't see any sores. You're looking to see if they're nice and pink and there's no lesions or anything like that. And stick out your tongue for me. The tongue should be moist like this and pink. You don't want it to be beefy red, which is like in pernicious anemia. You don't want it to be dry or cracked. That could be dehydration. Okay, you can put the tongue in. Then I want you to lift up your tongue for me and look for any lesions underneath the tongue. That's where mouth cancer can hang out, and I don't see any. Okay, you can close. Then while you're also looking at the gums, open up a little bit. You're gonna look around for cavities, any loose or broken teeth, no dental caries in there. Then, okay, sort of open up your mouth a little bit more, put your tongue down, and you're going to look at the soft and hard palate. Now, while you're in there, you want to look at the uvula. Make sure it is nice in midline, and his is nice in midline, and we're going to test cranial nerve 9, the glossopharyngeal. And so what I'm going to do is I'm going to have you say ah, and what you want is that uvula to move up. Okay, and then we're just going to test the gag reflex. I'm sort of just going to poke a little bit back there and elicit a gag reflex. Okay, there you go. The gag's really good. And cranial nerve 10, the vagus is intact because he's able to talk to me without hoarseness, and he's able to swallow. Then when you're done inspecting the mouth, be sure you take off your gloves and perform hand hygiene. Now moving on to the neck. So what we're going to do is we're going to inspect the neck first. So you're going to have the patient extend the neck up a little bit, and you're looking at that trachea. Is it midline? Look for any lesions and look for any lumps, like what you might see in thyroid problems like a goiter. And we don't see any of that. Then what we're going to do is we're going to test cranial nerve 11, which is the accessory nerve. So Ben, what I'm going to have you do is move your head side to side, up and down. Okay, and then shrug, try to shrug against my resistance. And he does that with ease, so that nerve is intact. Then we're going to place him at a 45-degree angle, and we're going to have him turn his head to the side. And what we're looking at is the jugular vein. We're looking for any jugular vein distension, JVD. So Ben, I'm going to just turn your head to the side like that, and we're looking for any distension of the vein, and we do not see any. Next, what we're going to do is we're going to palpate. So we're going to palpate that trachea just to confirm it is midline. And Ben, do you feel any tenderness or anything like that? Ask him if he feels any tenderness. And I don't feel any lumps. Then next what we're going to do is we're going to palpate the lymph nodes, all sites of those. And Ben, as I do this, tell me if you feel any tenderness. And what I'm feeling for is any hard lumps or anything that may be inflamed. So what we're going to do, turn a little bit this way. And there we go. We're going to start at the pre-auricular, which is right in front of the ears. Then we're going to go to the back of the ears, the post-auricular. Then we're going to go to the occipital, the parotid, jugulo-digastric. Then we're going to go to the submandibular, and then the submental. Then we're going to go to the superficial cervical, and then we're going to make our way down to the deep cervical chain. Any tenderness so far? Then we're going to go to the posterior cervical, and then right above the clavicle, we're going to go to the supraclavicular. And did not feel anything and no tenderness. Next, we're going to palpate the carotid artery, and this is one artery that you do not palpate bilaterally, you do one individually. So we're going to feel on this side, and you're going to find it next to where the groove of the neck and next to the trachea, and his is nice and bounding, it's 2+. Then we're just going to feel on the other side, and same strength, 2+. Then lastly, what we want to do is we're going to auscultate the carotid artery, and you're going to do one side at a time, and you're going to compare sides. And you're going to listen with the bell of your stethoscope, and we're listening for a bruit, which is a swishing sound. So Ben, what I'm going to do is I'm going to have you breathe in, breathe out, and hold it for me, okay? Go. Breathe in, breathe out. Okay, you can breathe normally now. Did not hear it on that side. Okay, breathe in, breathe out for me, and hold it. Okay, and I did not hear a bruit on that side as well. Now let's move to the upper extremities. So what we're going to do is we're going to inspect the extremities, and we're looking for any lesions, any redness, swelling, and this is a good time if they have a central line, an IV, that you look at that, make sure it's not red. Does the IV need to be changed? Does that PICC line or central line need a dressing change? Assess that. Then you can palpate, and what we're going to do is we're going to palpate our pulse, our radial artery. So feel those bilaterally, and they are 2+ and they're equal. Then we're going to check capillary refill, and to do that we're just going to press down on that nail bed and see how fast it comes back, and it's less than 2 seconds. Then we're going to check skin turgor by just pinching the skin and see how fast it goes back, and that was good. Then we're just going to look at the range and the motion of the fingers and the hands. Look at these joints in the hands. Do you see anything abnormal, like for instance like Herbadine or Bouchard's nodes, which are found in osteoarthritis? And ask the patient, are you having any pain in your hands or anything like that? No. Then you can palpate the brachial artery, which is found in the bends of the arm, and just feel those because that's another pulse site, and those are 2+. And just as a side note, if this was a patient that was getting dialysis and they had an AV fistula, you would want to palpate that and feel for the thrill, make sure that that is present up in that arm wherever their fistula is at. Then you want to test the muscle strength. So What we're going to do is I'm going to have you squeeze my fingers as hard as you can, okay? Okay, that's really good. Then I'm going to have you push up against my hands, and I'm going to push up against your arms, okay? Push. Okay, very good. Okay, and 5+ normal strength. Then we're just going to test put your hand underneath the elbow and just feel as you move the arm. Do you feel any grating, crepitus of those joints? A lot of times in arthritis, you can feel that. And move that bilaterally. Another thing you want to do with the upper extremities is to check for a drift. And what you will do is you'll have the patient hold out their arms and close their eyes, hold it up for about 10 seconds, and you're looking for a drift like this. So go ahead, do that and close your eyes, okay? And we're assessing to see if this hand will drift upward. And a lot of times, if a patient has had a stroke, okay, you can put them down, has had a stroke or something like that, you will see a drift. Next, we're moving on to the chest, and we're going to inspect the chest. We're looking for any abnormalities like lesions or any wounds, anything like that. We're also inspecting the patient's effort of breathing. Is it really labored? Are they using those accessory muscles to breathe? Also, we're looking at that anterior-posterior diameter. So turn to the side like that. And you're looking for that barreled chest. And it will be increased in patients with like COPD. They will have what's called the barreled chest. And now what we're going to do is we're going to listen to heart sounds, and then we're going to listen to lung sounds. So first, let's auscultate heart sounds, and we are going to do this in 5 locations, and they're based on where the valves are located. And I like to remember the mnemonic: all patients effectively take medicine, and the first letter of each word represents the valve except for effectively. So A would be aortic, P in patients would be pulmonic, effectively would be Erb's point, and this is just the halfway point between the base of the heart and the apex of the heart, and there's no valve location there. And then T is for tricuspid, and then M is for medicine. So again, using the diaphragm, we're going to listen at the right of the sternal border at the second intercostal space, and that's going to be the aortic valve. So to find that second intercostal space, find the sternal notch, go down to the angle of Lewis, then just go a little bit to the right, and you're in the second intercostal space. And this will be the aortic. And we're just listening, lub-dub, S1, S2. And S2, the dub, is going to be louder in this location. Then we're going to go a little bit over to where the pulmonic valve is found. That's on the left of the sternal border at the second intercostal space. So we're just right across. Again, just listening to lub-dub, and S2. Dub is going to be louder in this location. Then we're going to go a little bit down to the third intercostal space. And this is Erb's point. And again, you can hear lub-dub, but there's no specific valve here. Then we're going to go down to the fourth intercostal space. And this is where the tricuspid valve is. And lub, S1, is going to be the loudest at this location. Then we're going to go to the fifth intercostal space, mid-clavicular line, and we're going to listen to the mitral valve. And again, S1 is going to be loudest here, dub. And there's something special about this site. This is the point of maximal impulse. This is where you're going to listen for the apical pulse. So we're going to set here and we're going to count it for 1 full minute. And a normal apical pulse in an adult should be 60 to 100 beats per minute. And his apical pulse was 63. Then we're going to switch over with the bell of our stethoscope, and we're just going to repeat in those locations, and we're specifically listening for heart murmurs, so that swooshing, blowing sound. So that's what we're going to listen to with that. And I did not hear any. Now let's listen to lung sounds. Now when you're listening to lung sounds, you're listening for abnormal sounds. And here are some samples of some abnormal sounds that you may hear. Crackles. Wheezes. a friction rub, or stridor. First, we're going to listen anteriorly, and what we're going to do is we're going to listen with the diaphragm of our stethoscope, and we're going to start at the apex of the lungs, and we're going to always compare sides and just inch our way downward and assess all the lobes of that right and left lung. So first, let's start up here, okay? And Ben, I want you to take a good deep breath in and out. So here we go, apex. Okay, we're going to compare sides. Then we're going to move down to the second intercostal space, and this is going to help us assess the right upper lobe and the left upper lobe. So, another deep breath in and out. Then we're going to go down to the fourth intercostal space, and we're going to assess where our right middle lobe is and our left upper lobe, because remember, the right lung has 3 lobes and the left lung has 2 lobes. So let's listen to our left upper lobe. We're just going to go down a little bit more. Then we're going to go mid-axillary at the sixth intercostal space, and we're going to listen to the right and left lower lobes. So if you just want to turn to the side right there, take a good deep breath in for me. Okay, other side. Okay, now let's listen posteriorly. Again, using the diaphragm of the stethoscope, you're going to start listening at the apex and work your way down. And one thing to keep in mind when you're listening back here, you have the scapula, and you don't want to listen over those because you won't be able to hear the sound. So you're going to listen in between where the scapula and the spine are, so down in these regions right here. And again, we're just going to compare sides, and you can do this part at the end if you wanted to whenever you turn your patient over to look at their back side, but we're just going to go ahead and do it now. So we're going to start here in the apex, compare sides. Then we're going to find C7, which is that vertebral prominence. It's the big ball right there. You can't miss it. And go down to about T3, and you'll be in between the shoulder blades, and go a little bit in between the shoulder blades and the spine right in there, and you're going to assess the right and left upper lobes. Then from T3 to T10, we're just going to inch around, and we're going to listen to the right and left lower lobes. Okay, now we're going to assess the abdomen, and remember, we're switching our sequence in how we assess. We're going to do inspection, auscultation, and then percussion or palpation. So we're going to do auscultation second. So whenever you're looking and assessing the abdomen, have the patient lay on their back, and what we're going to do is we're going to inspect the abdomen. And first I want to ask Ben, are you having any stomach issues at all?
No.
No? Okay, and when was your last bowel movement?
Yesterday morning.
Yesterday morning. And how are you urinating? Do you have any pain while you're peeing? Do you have problems starting a stream? Any discharge, anything like that?
Nope, it's normal.
Okay, and with your male patients, you want to ask about that due to prostate enlargement with starting a stream. And if he was female, I would ask him when his last menstrual period was, and also, again, ask the female patient about urinating and things like that. Now, if the patient had a Foley, this is the time when you would want to look at the urine, inspect the Foley, and look at that. Just conglomerate your urinary system and your GI system together. Okay, so we're inspecting the abdomen. We're looking at the abdominal contour, and this patient's is scaphoid. It goes in a little bit. You can also have flat rounded or protuberant. And also we're going to note if there's any pulsations. A lot of times in this area right here on thin patients, like with Ben, I can see the aortic pulsation in this patient. It's right above the umbilicus. And looking at the belly button and checking for any masses. Do we see any hernias or anything like that? Also, if your patient had any wounds, you would want to look at that. And if they had a PEG tube, you would want to assess the site, make sure it's not red, and ask them how it feels. And with your ostomies, you would want to look at the stoma and make sure it is like a rosy pink color. It's not a dusky cyanotic color, and it's not prolapse. And look and see what type of stool it's putting out. And note that, note the smell, note if the bag needs to be changed, anything like that. So now we're ready to listen to the bowel sounds. And what we're going to do is we're going to listen with the diaphragm of our stethoscope, and we are going to start in the right lower quadrant and work our way clockwise. And we're going to listen to all 4 quadrants, and you should hear 5 to 30 sounds per minute. And if you don't hear any bowel sounds, you need to listen for 5 full minutes. And you need to note, are these normal, are they hyperactive or hypoactive? So let's listen. Okay, this is our right lower quadrant. We're going to move up to the right upper quadrant. Move over to the left upper quadrant. And then down to the left lower quadrant. And bowel sounds are normal. Now we're going to listen for vascular sounds, and you're going to do this with the bell of your stethoscope, and we're going to listen at the aortic, we're going to listen at the renal arteries, iliac arteries, and you could listen at the femoral arteries if you needed to. So you're going to listen at the aorta artery, and it's a little bit below the xiphoid process and a little bit above the umbilicus. So about right here, and we're listening for like a blowing, swishing sound, which would represent a bruit. Okay, and none is noted. Then we're going to listen at the right and left renal arteries, which is a little bit down from the aorta location. So here's the right. Okay, none noted, and then over the left. Then we're going to listen at the iliac, and it's a little bit below the belly button, right here. And this is the iliac artery. And then listen on the other side. And again, like I pointed out, you could listen at the femoral artery in the groin if you needed to. Now we're going to do palpation. First, we're going to do light palpation, then deep. And Ben, as I do this, please tell me if you feel any pain or tenderness. So first, we're going to do light palpation. We'll just start in the right lower quadrant and work our way around. And you're going to go about 2 centimeters. And you're just feeling for any rigidity, any lumps, masses, anything like that. How's that feel?
It feels fine.
Okay. Okay, now we're going to do deep palpation. And we're going to go about 4 to 5 centimeters, so a lot more deep. And again, you're just feeling for any masses, lumps, and Ben, tell me if you have any tenderness. And sometimes you can do this with 2 hands if need be, if you're not strong enough like me. Feeling anything?
No.
Feels nice and soft. Heard some belly sounds. That's why you do this after you listen, because you stimulate it. Okay, everything felt good. Now we're going to assess the lower extremities. So first what we're going to do is we're going to inspect. We're going to look at the color from the legs to the toes, making sure it's nice and pink. And here we see that Ben has a little bit of a tan line here. And we're looking at the hair growth as well. You want to make sure there's normal hair growth, because in PVD you will see hairless, shiny, thin legs. And here we have excellent hair growth. And also, do you see any abnormal swelling just right off the bat before you've even touched the patient? And look at the legs and the feet for any swelling, redness, swelling. Do you have any pain or anything in your legs, anything like that? And look at the joints, make sure there's no redness on the joints, because a lot of times with gout, it likes to start out in the big toe, so make sure that everything looks good. And then on your diabetic patients, make sure you look at the bottoms of their feet, because these patients don't have the best feeling in their feet. So their shoes could be wearing on them, or they could have stepped on something and not even know it. So inspect those feet, make sure there's no ulcers or anything like that needs to be addressed. Also look at the toenails. Do the toenails look healthy, or is there fungus, or are they missing toenails? They have a really bad ingrown toenail. So assess for that. Next, you want to palpate your pulses. We'll palpate the popliteal pulses, which are behind the knee. And those are about 2+, they're equal bilaterally. And I'm just feeling his legs, they're nice and warm. And I'm going to push over his tibia firmly, and I'm seeing if there's any edema. So push there. And if there is edema, a lot of times whenever you push down, it's like this hard-like type gel. It'll just separate, and your finger will leave this indentation. And here, we don't have any. Now we're going to palpate on the feet, and we're going to feel on the pulses. And I'm going to don gloves, perform hand hygiene, don gloves, and we're going to feel on the pulses in the feet. We're going to feel on the posterior tibial. And 2+, really good. And then we're going to feel the dorsalis pedis, which is on top of the foot. 2+ with that. And if you can't ever find these, because sometimes these are hard to find in patients, you can get a Doppler if you have one on your floor. Next, I'm going to check the capillary refill on his toes, just like how we did with the fingers by pushing down. In less than 2 seconds. Check the other one. Okay, now I'm going to have him push against my hands. Push against my hands, Ben. Okay, good job. Now I'm going to have you raise your legs against resistance. Good job. Now we're going to check the Babinski reflex, and you can use your reflex hammer for this and use the end of it, or you can use your finger if you don't have that. And what we're going to do is we're going to take this up through the ball of the foot and curve it, and we're looking for the toes to curl in, which would be a negative normal response. So let's check that. Okay. Okay, and that was normal. Then we're going to doff our gloves and perform hand hygiene. And next we're going to assess the back. So whenever you're looking at the back side, you're going to look from the head all the way down at the back, and you really want to pay attention to any abnormal moles, lesions, wounds, anything like that, and assessing for skin breakdown, especially on your patients who are mobile. So that would really be concentrating on in the backside area, on the coccyx, because that's where a lot of breakdown happens, and on the back of those heels, if you couldn't see it whenever you were assessing the feet. And also you could, if you hadn't already, you could listen to the lung sounds as you have the patient over on the back. Okay, so that wraps up the nursing head to toe assessment. Now,
guy, my people, muchanze yanda muke tunani. Baka zuwa gurin meeting ko wajen bita. Baka zuwa online meeting. Zahirin ma baka zuwa. Baka cewa komai a maganganun da ake a chat group ko a WhatsApp group. Baka sanya kanka cikin komai da ake yi na wannan kamfani na harkar business din. Baka nuna kanka ta ko ta ina da abubuwan da ake a wannan kamfani. Duka dinka cewa wannan kasuwanci ba ta yiwuwa. Kuma ka naɗe hannayenka baka cewa komai. Yar uwa, dan uwa, da ni da kai, da ita da shi, waye ne baya aikin yanda ya kamata? Waye ne wanda baya gudanar da wannan aikin kamfanin yanda ya dace? Da kai kake ta cewa wannan abun baya yiwuwa, wannan abun ƙarya ne, wannan abun fo wannan ne, wannan abun ba gaskiya bane. Kai ne kake yaudaran kanka, ba kai bane, ba ke bace, ba kya yin aikin yanda ya dace ko yanda aka ce a yi, shi yasa ba ka ganin komai, shi yasa ba kya ganin komai a kowane ƙarshen sati. Ba ka yin komai amma ka je kana ta cewa business din ba ta yi. Ba ka yin komai amma ka je kana ta cewa business din ba gaskiya bane. Ka naɗe hannu, ka sa lalaci, ka sa laziness, duk wani abu na laziness ka sa shi a cikin tunaninka, duk wani abu na excuses ka sa shi a cikin tunaninka, kuma ka je kana ta cewa wannan business din baya yiwuwa. ko dai kana tunanin bonus point zai faɗo daga sama ne a baka, ko dai kana tunanin kuɗi zai na saukowa daga sama kawai a ringa sa maka a accountinka a kowane sati da aka ce za a na biyan ka, ko dai kana tunanin haka kawai Allah zai zubo maka kuɗi akan tebur ko abinci akan tebur ka ringa ci haka kawai. Dole sai mun fita mun nema, dole sai mun fita ka nemo, dole ka sha wahala kafin ka samu, dole sai ka zama abin da ka zama kafin ka yi jajircewa, iya jajircewa da himma da haƙuri da dauriya da sa ƙoƙari a cikin lamuran ga kafin ka kai ga inda kake so a rayuwa. So idan dai har haka kake tunani kuɗi za su zubo ko point za su zubo ko kuɗin da suke badawa na multisim za su na zuwa kowane sati kawai baka yi komai ba, ka canja tunani. Dan Allah haka kake tunani? Haka kake tunani? Kawai point za su na zubowa a accounting ka baka yi rijistar kowa ba, baka gaya wa kowa, baka sai da maganin kowa, baka yi wa kowa magana ba, haka kake tunani? Dan maso, dan Allah dan maso, wani in taba jikinka ko in ji temperature ka yake, haka anya ba zazzabi kake da shi ba? Dan Allah je ka yi abin da ya kamata, je ka gayyato mutane, je ka yi silan kawo mutane wannan business domin yin hakan shine zai baka daman ka ringa samun kuɗi a wannan kamfani, domin kuɗin da ake samu a multi-stream TM limited ba ƙarya ba ne, kowane sati muna samun shi. Dama ma ta samu ga ka a Gombe nan kai tsaye, kana da service center sama da guda 5, kana da superstore ɗaya. Me matsalan ka na products ka a koyaushe ka neme shi, al'umma suna kewaye da kai, kullum kana da daman yadda za ka yi ka samu wannan kuɗin. Zan dakata a nan, ni ne Nurse Pashka daga Gombe State. Have a nice day.